Jerry Garcia. Raise your hand if you know who Jerry Garcia is. Good. Just about every generation knows, but a great lyricist and guitarist from the Grateful Dead. Basically said, somebody has got to do something. Jerry Garcia. Why don't we open this conference today? A great conference, by the way. Really, if you stick through it 4 hours, you're going to know more than 99.9% of people in America. I say that really out of admiration for a great menu for the course of today that'll be presented to you. I'll save time for some questions and answers, but what I'd like to do, I'm going to go fast. And I go fast because everybody in here looking through the attendees kind of gets it in terms of the substance and the sense of time and sense of place in healthcare. But what I want to do is sort of set this horizon and this perspective for you so that over the course of the morning that you will be able to say, oh yeah, I see exactly where that fits. And I'll start, my menu is basically what is Obamacare, because we got to know what it is because it's the law of the land and we're going to all be working with it. But the message will keep coming back again and again that all healthcare is local. It's that nurse and that patient. Maybe not the patient, maybe the consumer, but maybe somebody who hadn't even accessed the healthcare system, where they go, how they interact, how they treat themselves. That's local stuff. But the framework that's set, and I'll start federal and the governor end sort of with the state, very much has shifted from the federal government and all the activity from the last 2 years, and we'll do a little inside baseball there, to the state level. And then as we talk about business and employers over the course of the morning, it's where the action's at. But big picture, we're going to go fast, but we'll have the framework for you. So what I'm going to do, how we got there, what the implications of how we got there. The greatness of America is in jeopardy. Why is that? And I say that with no exaggeration. As majority leader of the Senate, I travel to 42 countries. Other countries are moving faster, growing faster, producing smarter people than the United States, are growing 3 to 4 times faster. And if we don't do something, going back to Jerry Garcia, we're going to lose that greatness of America. And then I'm going to tee up solutions. Obviously, I'm going to hit solutions in about 8 minutes. Impossible for me, but over the course of the morning, as you see it, you'll say, yep, something can be done at the federal level. Yep, something can be done at the state level. The providers, meaning the nurses and the doctors and the systems and the business community just touch, because we'll talk more about that, in individuals who are making smart decisions, or we need to empower them to make smart decisions as we go through. So here we go. What is Obamacare? This is the best way to think of it. 150 to 170 million people. We are an employer-based healthcare system. On all the debate you hear about government takeover and all, we are an employer-based healthcare system today. The platform upon which all healthcare reform has to be built there. Will the business community step up? It's a question. It's been marginal in the past. And on top of that, this bill, Obamacare, says we're going to give universal health care. Now, President Obama says it's going to cost you less, your health care costs are going to go down, everybody will get health care. It's not true. You know it's not true. But the goal of universal care is true. But the reality is, as I show, really only 92% of residents will be covered. So if you're in the hospital business, you're in the home care business, and you think everybody's going to have health insurance, they're not in 2020. Even if this bill is implemented perfectly, there will still be the cost distribution and the cost shifting and the inefficiencies there. Yet the goal was universal care. How do you get there? 2 ways. This is Obamacare sort of boiled down to the essence of what it is. Number one, health insurance market reforms. Some good stuff, and that's what's touted, whether it's a pre-existing illness or a level playing field or making it easier to shop, more pooling going on, all good stuff, just about everybody agrees with it. The number two is the mandate. The mandate itself, this bill, from an access standpoint, and in part from a cost standpoint, does depend on the individual mandate. And I will jump and talk just briefly about the constitutionality of it and repeal and all the inside baseball stuff, but that's it. Health insurance reforms, and number two, the mandate. What it does, the impact, because it's a coverage bill and not a reform bill, is two. It takes 32 million people who don't have insurance today and puts half of them, 16 million people, into Medicaid, a state-run think the governor talking to us at lunch today, and the other 16 million of the 32 million people puts them into exchanges. These are health markets. But where are they? They're not in Washington, D.C., and they're not in Birmingham or Tuscaloosa, but these exchanges are statewide exchanges. Again, it's kind of appropriate that we're ending with the governor today to wrap things up, because in truth what this bill does, it takes a framework and pushes the operational responsibility 100% really down to the state level. The federalism argument. Huge responsibility on the states. Now this is probably the best way to actually look at, well, let me run through it. It's a coverage bill, it's not a reform bill. Spending is not going to go down, spending is going to go up. You can argue with it and all, at the end of the day, more money is going to be spent on health care. You're going to still have 20 to 25 million people uninsured. The government will be paying, more money will flow through the government, most of the implementations to the private sector, but more money for health care will be flowing through the government. And reimbursement to providers, nurses, doctors, and hospitals and facilities is going to fall. It's not going to go up. It's not going to go up. It's going to fall over time. So what does it mean visually? And this is, you'll love this, but visually what it actually does is the following. I'm going to show a chart, and on the chart is going to be age, 5 years of age, 10 years of age, 20 years of age, 30 years of age. If you look here, 65 years of age, somebody who's 35 years of age. Over here, just the number of people, the population. The healthcare system today is this, and let me fill in a few of the blanks for you. Private, employer-sponsored, we'll talk more about that, 150 to 170 million people, depending on how you count them. But look at, that's the bulk. It's everybody under this line. And if you look at everybody in America today, look how many are actually in this employer-sponsored plan. A lot coming through. That's where the reform, I think, actually must be led. Medicare, our public plan for our seniors, greater than 65 years of age, is 43 million people. Our Medicaid, our plan, which is under this line right here, which is 5 years of age, 10 years of age, 15 years of age. Most of the people in Medicaid are actually under 20 years of age, as you can see. It's 45 million people. I'll show you shortly what healthcare reform is going to do. We have in individual plans about 14 million people, but this leaves 50 million people uninsured. Don't you love this chart? It's a good chart. I made the chart, but it's a good chart. Because we know anything about this stuff, all of a sudden, yeah, I get this makes sense. Also the importance, because everybody's going to say how important employers are. This is why they're so important. Look at this mass of people that are in there. Okay, so what is Obamacare going to do? If it goes perfectly, and this is what it does. And reassuring to some of you, not reassuring to other of you. Newly insured 32 million people. Remember, 16 new people in the exchanges, 16 in Medicaid, all state run. But what people don't tell you is the fact there'll be 23 million people still uninsured. For example, the 13 million non-U.S. citizens which are not covered by this bill, just for example, coming in. I won't talk about that, but just so you know, it's not true universal coverage. There'll be 16 million more people in Medicaid. There will be, forget the individual plans, some shifting around the individual plans. The employer-sponsored plans, remember we were worried about, a lot of people were worried about a public plan running them out of business, the monopolistic purchasing power of the government, lowballing, running out, Blue Cross, Blue Shield, Humana, and all that. It's not going to happen. In truth, it's not going to change very much. The employer is still going to be the dominant player as we go forward. 4 million, so that'll change by about 4 million. Let me see. The exchange is 24 million. But I thought you said 16 million, now you say 24. It's 16 million net people who are going to be in these state-run exchanges, and by the way, they don't exist. They've not been invented. They've not been invented. Massachusetts has one that's working okay, but everybody agrees that's not the model that they're going to use in their state. So they don't exist today, and they need to be up and running shortly. A huge challenge for the government as we go forward. Have you ever wondered why you felt so bad? You're going to love this too. The last 2 years. And this is going to grab your gut. You haven't seen this either, but you're going to love it. Here is where we are today. Black and blue is bad, 10% unemployment, 9%, 8%. Yellow is pretty good. And this is where you are in January of 2007. Now I'm going to call out the month so you don't have to look at the top. But I'm going to walk you through from 2007 to where we are today. And it'll explain a little bit, and I'll talk about the impact on healthcare and why the coverage aspect, why the uninsured matter, why it is important to bring the uninsured into the market today. If you don't have any insurance, you die sooner. Your cancer's treated later. That breast mask, you wait for it to get a little bit bigger before you go to the emergency room, and yes, it's taken care of in the emergency room, but it's just later coming in. So here we go. This is January 2007, and we're going to go shortly here to March, and then April, and then May, and then coming through. April 2007, July 2007, October 2007, January 2008, April 2008, July 2008, more black, beginning to get depressing right now, December 2008, March 2009, I'm really depressed, June 2009, August 2009, December 2009, January 2010, March 2010, May 2010, July 2010, September 2010, November 2010. And obviously it hasn't gotten better, any better at all. Now, lots of implications for you. Lots of implications for you in terms of business, because there's so many business people here who are here today. And this is why you just this feeling of, are we going to get out of this thing? It has implications for the state and the state budgets, which I'll show you shortly. If you look at the left-hand side of this chart, that's the number of uninsured, and in an 18-month period, we went from 45 to 50 million people. 10% increase over an 18-month period. Recession, the economy matters to healthcare. The right side of the chart, you look at Medicaid coverage. Medicaid, by the way, is for the lower socioeconomic people, but it's not a very egalitarian sort of thing. It's sort of kind of categorical but spotty. If you're a single guy, you're not covered by Medicaid. If you're a mom with kids, you are, no matter how poor you are, if you're a single guy, most states have an exclusion to cover you, which is wrong, and that has been changed in the legislation. But in Medicaid, there was about a 20% increase over an 18-month period, 2007 to 2009, to 44 million people uninsured. So this recession does matter. Coverage matters. How did we get here and the implications? This is fun, and this is sort of inside baseball. This is more than you're going to want to know, but since you have somebody who follows us very closely on the inside, it's kind of fun, because it shows both the limitations of our legislative process, but the great value and the great power of our legislative process in addressing issues that are important. Basically, the coverage issue, not the cost issue, and really not the quality issue itself. Don't try to read this. This is mainly written for impact, but this is healthcare reform starting in 2009, 2010, 2011 to where we are today. These are the major events that decisions were made and turning points. And again, going inside baseball, let me show you just a little bit of it. 2009, the President of the United States basically came out and he said, let there be no doubt, healthcare reform cannot wait. It must not wait, and it will not wait another year. Why is that important? President Obama led healthcare. The American people, to be honest with you, just sort of fourth or fifth on any of the polls on what's important to you. It was Iraq, it was security, it's the recession, it's jobs. President Obama said, I don't care if you're interested in that, I'm leading on health care. Now, on the one hand, you can be cynical about that. On the other hand, he is addressing probably the single most fundamental social problem that has not been addressed since Harry Truman in the United States of America. So you got to admire it. He said, I'm going for it. Like Babe Ruth, there's a right field, pointing to it, he said, I'm going to go for it and do it. So on June 1st, he cut a deal. Basically, he said, I can't do this thing. Everybody else tried it, so I'm going to do something different. I'm going to get my enemies there. I'm going to get the Blue Cross Blue Shields, who thank you for your support today. I'm going to get the drug companies, the bad guys. Pfizer, thank you for your support today. I'm going to get all the AMA, all those doctors out there who want fee-for-service and want to play golf. Now I'm going to get them in there, and he cut a deal with everyone. He said, drug companies, you put $100 billion on the table, or I'm only going to make you put $100 billion, you vote for me. They said yes. The AMA, most physicians didn't like this stuff. They don't like government, but the AMA came in and cut a deal with them. And it cost a little bit, but they said, listen, it's going to cost. So President Obama had the 5 trade groups out there going in. Leaders, I give a talk on leadership and lessons learned. Bring your enemies in, co-opt them early on, and look how early he did it in the reform. Smartly, wisely, I say this out of great admiration. In July, a bill was put out by the House, and then Sarah Palin caught fire in her blog, a simple blog statement about death panels. And in 2009, in August, everything's topsy-turvy. America stood up and said, wait a minute, we don't want you to move too fast. A little bit later in August, Ted Kennedy died. Ted Kennedy, we were talking about healthcare disparities, some of us earlier this morning, is an icon. He's a legislator. He doesn't drive anything through on his agenda. He bargains, he negotiates, he's got great intentions. If he had not died, this bill would look totally different. It would have been a bipartisan bill, I promise you. I worked with him for 12 years, but unfortunately, he died. And I put it on the slide because things would have been very, very different. Not just in terms of the bill, but in terms of what the governor is going to talk to you about today, the implementation of this bill, totally colored by the fact that this is a partisan bill and that half of America was excluded from the room. So now nobody has ownership of this legislation at all. And most people don't like it. If you look at the polls out there, it's probably 55-45. So with no ownership, because it was pushed through so quickly, the lack of bipartisanship has an impact, not so much in passing the bill, but over the 10 years of implementation. Would have been very, very different. Senate bill passed in October. In November, this is 2009, for the first time, the constitutionality question arose. General Motors, the federal government owns General Motors. Can they come and tell you, for the good of the country, that you have to buy a GM car? Under the Commerce Clause, most people say, of course not. But there is no difference than that. For the good of the country, because we have a vested interest in health care, you have to buy a health care plan. It's no different, and that's the constitutional question. Orrin Hatch brought it up in 2009. I'll come back and speak to that very quickly. The House passed the bill, and then Harry Reid says the public option, we're going to drop it in 2009. Big deal, because from the liberal standpoint, you want a public option. You want Medicare expanded. You want Medicare to be that whole chart I showed you, and not the private sector, and not businesses, and not employers, and not consumers. If you're for the public plan or universal health care by government, that's what you want. But Harry Reid stood up and said, we don't have the votes for that. We're going to pull it out. Huge implication. Rejecting the left. You don't hear that from the right, but the left was rejected, and Obama said, we're going to reject the left. Really pretty powerful statement being made. Moved to 2010, Harry Reid basically to the unions, because the unions didn't like this bill at all, cut a deal with the unions and said it doesn't apply to you in terms of taxing the Cadillac, the very expensive plan, for another 8 years. So all the union guys said, 8 years, I'll be out of here, and cut the deal. Pretty smart in terms of getting legislation through, very smart. This is what I used to have to do for a living. Thank goodness I don't have to do it anymore. This is what you do for a living. This is Washington, D.C. on the inside. And then all of a sudden, we got old Scott Brown. What Scott Brown, now, to pass anything in Washington, you have to have 60 votes. And the Democrats had 60 votes. Republicans had 40. They're part of a lot of fantastic swings in America, which I love. And so they have enough votes to pass. Yet in the Senate, my body, you have to have 60 votes to pass anything. Except, as I'll tell you in a little bit, there is one door you can go through. One door, and pass it at 50. But when Scott Brown was elected, where you did have a similar to an Obamacare type plan, it basically said, wait a minute, slow down, but it also meant 41 votes that the Republicans had, so you can't jam this thing through. Or so people thought, but very important at the time. And then President Obama, a year later at the State of the Union message, when America cared about jobs and the economy and that map that I showed you, which makes it so gut-wrenching and dramatic, President Obama didn't talk about jobs. He talked about health care. Again, you can be cynical about it, but it shows leadership. A dramatic problem, the President of the United States leading on it. And then the next day, they actually had a sort of a town meeting, and Republicans, for the first time, with Lamar Alexander, who was from Tennessee, they started putting some ideas on the table, so they didn't sound like they had no ideas. So America, for really the first time, said Republicans, no, they're not just saying no, but they do have some ideas. Thank goodness they did that, because I would take a beating everywhere I went. You know, Republicans would just say no. But so fascinating in terms of overall development. And then Harry Reid said reconciliation. I'll come back and tell you a little bit about that. The Congressional Budget Office says, no, you know what? this debt and deficit and all that stuff, this bill's a moneymaker. So the individual is saying, you mean my health care costs are going to go down, I'm going to get more health care, we're going to insure 40 million more people, and it's going to save the country money. How could the CBO say that? This is inside baseball, but the Congressional Budget Office, nonpartisan, actuarial, they have to report not what is plausible, but what they're given on a piece of paper. And the piece of paper basically said, we're going to cut Medicare by $500 billion. And so they take that and say, well, that's $500 billion. So of course the debt's going to go down and the deficit's going to go down. But the important thing for you to know, in Washington, we all know it, but you to know is when the CBO speaks, it doesn't speak on plausibility or likelihood, because that's not going to happen. Everybody knows it's not going to happen. It's always proposed. But they have to legislate on whatever the piece of paper comes over from the Congress. So pretty interesting. But it had an impact because everybody said, God, it's a moneymaker, this bill. I'm getting a good deal as an individual, and the federal government's getting a good deal. So pretty smart move overall. House passed the Senate bill. President Obama signed it into law. But on that same day, these lawsuits were on the constitutionality, both in Virginia and Florida. The same day that bill was signed, the lawsuits for the constitutionality were passed. A little bit more on that in a second. It was really just in September, about 3 or 4 or 5 months later, the House said, we're going to repeal and replace. That mantra started going, and then we actually had the elections. Colossal. Does this stuff have an impact? Not because of health care, but in part because of sort of government coming bigger and bigger. It does have an impact on the backs of health care, which became the sort of iconographic image of where the administration was going. This is what happened. Epical. Now, I came in 1994, landslide year for us. This thing blew that away. I'll just use the examples of the House of Representatives graphically so you can really get a feel in your gut for it. This was the House of Representatives. Blue is Democrat, red is Republican. Remember, 435 in the House. They run every 2 years. And I could do the same thing with the Senate, not quite as dramatic. But this is what happened over a 24-hour period, in large part because of health care. Let me back. I don't know if I can back up. You saw the red. You saw the red coming as it came through. It filled that whole space. Number of new House members. Is our government, are people there forever? Well, these big elections are not there forever, and the white boxes are freshman House members who've never been in Washington before, but look how many there are. Bang. They've never been there. They're seeing Washington for the first time, a large part based on this bill. Just if somebody says, is it really that colossal, these elections? An answer is yes. There were, and this has never been done in the history of the country, at the state, again, remember, everything's going to be at the state level now. At the state legislative level, there were 680 seats that went from Democrat to Republican. In my year, 1994, a landslide year, it was about 400. So this isn't just in the House of Representatives, out there, passions of the people. It was in the United States Senate with a pickup, and in the state legislatures, and at the governor's races, it was a landslide. I say that because they're the ones, if we're going to build, fix, not repeal, but build, fix, modify, there are a lot of new people coming in today, and there's been a massive turnover of people really from a party who have no ownership in this bill. So you'll see that play out a little bit as we go forward. In 2011, what has happened so far, the House voted to repeal. There have been 2 big lawsuits saying the bill is unconstitutional. Some smaller courts, not the district courts, smaller courts have said it is constitutional, so we'll wait and see. And then we had the Senate who basically said that, no, we're not going to repeal it. The Senate doesn't have majority control yet. And I'll show you just a little bit to give you a little flavor of where we are today in terms of the discussion.
For all of us who oppose the health care bill, today we reaffirm our commitment to work a little harder to get it right. We can't afford to get it wrong. So I urge my colleagues to move beyond party affiliation. Just look at the facts before us. If everyone in this chamber evaluated this bill for what it is, we'd repeal it right now. And then we begin to work on achieving our mutual goal of delivering health care at a higher quality for lower costs. Let's not miss this opportunity. Mr. President, I send the amendment to the desk and ask its...
This was all on the day of the repeal vote last month.
This healthcare bill is so fatally flawed it can't be fixed. The only option, contrary to what happened a year ago, is to go back and in a bipartisan way work to build solutions to the healthcare challenges a step at a time, for once and for all, instead of compounding problems, solve them.
I consider it an outrage that some of our colleagues want to repeal a law that is designed to improve the lives of millions of Americans. The push to repeal health care reform, I think, is the worst kind of hypocrisy, coming from this place and at the other end of the Capitol.
So that's where we are today. Can you repeal a bill? First of all, just so you'll know, I am out there basically, this is the law of the land. 70% of this law is very good. 30% of it really radically needs to be fixed, just so you'll know it's my bias, and I want to present everything as objectively, but that's the way I feel, so I'm not out there pushing for repeal. But then people say, you can't repeal a law that this massive, that was passed in the way through the Senate, can't really be repealed? And the answer is yes. In 1989, the Medicare Catastrophic Act, which focused on Medicare, did increase taxes some, didn't promise seniors a whole lot, but a very popular bill at the time, passed on June 8th, 1988. And then up in Chicago, Dan Rostenkowski had a town meeting with about this many people, and he was bragging on the bill, and he thought he was in touch with the way people really felt at the time. Remember, this was after June, August, that's a year later, year and a half later, about a little over a year later, and all of a sudden people started standing up and saying, you're wrong. You lost touch with the people. You didn't reflect really what we need. You didn't reflect what we want. And he said, oh, well, yes, we did. We gave you what was good for you, good for America, and what was right. And he went out the door, and he didn't get very far. He got into his car, and then this woman, Leona Kozian, jumped up on the hood of the car. And that picture, this before Facebook, internet, Twitter, and all, that picture went around America, and indeed, as really a product of that picture, the catastrophic coverage was totally repealed by the president December, a year and a half later. So repeal can occur. It's not going to occur, I predict, but it can occur. So all this repeal stuff is rhetoric for the most part, because people don't like it. They weren't in the room. They didn't write it. But it could happen. It could happen. Don't think that it will, and I think that's not the direction that we should go in today. So 3 things. This is what we just went through. More than you wanted to know, but it's kind of fun to see how legislation passes. And this is big legislation. This is landmark historical legislation. 3 things I mentioned. Public option, rejecting the left. These are the 3 most important things. The President of the United States, wherever he's going to be in the future in terms of coming back from the left to sort of being center or center-left, which is where he looks like he's going to be, he rejected the left. He just flat out, President Obama rejected the left. Number 2 is this reconciliation. Huge mistake. I wrote an editorial February 23rd in New York in the Wall Street Journal of that year in the middle of this debate, and Harry Reid to the president said, don't do it. I passed probably 3,000 to 4,000 pieces of legislation. We used reconciliation 3 times. Passed that much, used it 3 times. We used it for budgetary. It's to reconcile the budget. But you can legally do it. And what it does, it lowers the threshold from passing something from 60 votes in the Senate to 50. The door, instead of being 60-vote threshold to push a bill through, it makes it 50 votes, so a much bigger door, easy to pass. The problem is it makes it 100% partisan. And the implications of it being partisan and jammed through the door mean that nobody has ownership. So when the governor talks to you today about the problems he has, the Republicans probably aren't going to pay that much attention because they're bad problems, but they didn't create them in their own mind because they weren't in the room. Reconciliation was a huge mistake. It wouldn't have happened if Senator Kennedy had been there. And then the 3rd issue is this constitutionality. And just to comment, the 2 district courts there have said it's unconstitutional. Because it was jammed through so quickly, there wasn't a severability clause. So you got this big bill out here, and if one part of it, the individual mandate, is unconstitutional, it makes the whole bill unconstitutional. That's a product of the bill being jammed through, and you didn't write 3 paragraphs in there saying that the bill is severable. In truth, it'll probably be fixed, but it's another example of why you can't rush things through and expect, if they're very tough, to be implemented smoothly over the ensuing 10 years. These are challenges which have to be overcome. Let's see here. Matt, why don't you go up, because I'm going to need to get my slides back up, and I don't have my thing. All right, so don't pay attention to this while we fix that. I'm going to move to the third point. Biggest problem we have in America today is what? We don't have time to talk about it. It's the debt. The debt itself is driven by what? The debt and the greatness of America really determines on this debt. Of our debt, say it's $14 trillion today, it's grown to $21 trillion no matter what. Of the $14 trillion, 2/3 of it is owed to other countries. Very different than after World War II when we owed it to ourselves. Of the 2/3 that we owe overseas, half of it's to one country, China. What's the big deal about that? China is moving, it's hopping, growing at 10%, entrepreneurial, GM's building all their cars and selling them all there, it's moving. The problem is that they're growing so much, why don't they invest in themselves instead of us? And if they pull back and don't invest in us, we don't have anywhere else to go. The greatness of America is determined by the debt. What determines the debt? The entitlements. Oh, there we go. What determines let me see where I am real quick here. All right, so greatness of America, we got it. Debt. And what we're going to walk through real quick are debts driven by the entitlements. What are the entitlements that are driven? It's health care. What about the health care is Medicare and Medicaid? That's the high cost not addressed in this bill. And that really is going to, as we heard Dr. Hardman talk about this morning, it's going to a value system, and that really is our call to action. But if you really actually go through these, greatness of America really comes back to the debt. The debt itself, graphically, is this, percent of GDP. Right now, where we are, actually, let me blow this up a little bit for you. This is where we are today. This is percent of GDP is our debt. And we're right at about 60% of our overall economy, a pie chart, 60% of it we owe other countries. The problem that we have is where we're going if we do nothing. And what you can see from this chart is in about 2020, about 110%, and we hit that 110%. Physically, we just can't survive there. Interest rates go sky high. We ultimately have inflation coming through. If you look, is it President Bush, President Obama, none of that really matters. But if you go up to 2008 in terms of who is in charge, and that's mainly a political argument, but this is the deficit itself. Under Bush, predominantly Republican, then the Democrats came in here, and you can see where we are today. So you see how the argument can be made, well, this is happening while the Congress was controlled by the Democrats. In truth, a lot of the policy is determined back here. So the argument itself, it doesn't matter. What this does show is that since 2008, in part the recession, but not mainly the recession, we're in real trouble. We're in real trouble coming through, and there's a lot that we need to do. The entitlements themselves, so we got it. Greatness of America, the debt, the entitlements, Social Security, Medicare, Medicaid, it is all in health care. And the best chart to show that is this one right here. This basically shows spending from 2008 to 2078. Social Security as a percent of GDP is not increasing very much. It's pretty easy to fix as well. Other federal non-interest spending that they're spending in Washington, the stuff that President Obama is dealing with right now, cutting this 9% part of the budget and the freeze, all you read about in the paper, it's not really very much of a problem now. The problem as we go through is Medicare and Medicaid. Greatness of America, entitlement or debt, entitlements, it's healthcare driven. And so what do we do? Where do we go? Where do we actually go from here? Is healthcare cost? There's nothing in this bill that addresses healthcare cost. That is going to be the answer of what happens at the state level and in the private sector and in each and every community. It's not going to be dictated by Washington, D.C. It's not a part of this legislation. It has to be addressed. So here we come back. Who's going to solve this mess? Jerry Garcia. He said something has got to happen, and that's what he says. It's just incredibly pathetic that it has to be us. It's you. Literally, it's you and me, and it's not Washington and Lautenberg and McConnell and the people in Washington, President Obama. It is the innovation, it's the creativity, it is the energy, it's the dynamism, it's what made America great. But we have to come together and actually address that. So what I'm going to do very, very quickly in a few minutes is not give you solutions or actions, but give you sort of examples. because you'll be dealing with that as you go through. These are big problems. Over the last 50 years in the country, cost and spending in this country, I call it the 2.5% rule, has gone up 2.5% for health care, has gone up 2.5% faster than inflation and growth in the economy. That simply can't be sustained over time. How are we going to address that? So let's start real quickly with the federal government. I basically showed you that the entitlement problem, the debt problem, is a health care problem, Medicare and Medicaid. Can Medicare be fixed? It can't be fixed in the approach of cutting $500 billion out of Medicare, because doctors are not going to continue to practice. I encourage none of my 3 sons to go into the practice of medicine, and I love it. I love it. It's the best thing I was doing. A year ago, I was in Haiti doing surgery, responding to a disaster. It's the greatest profession out there. But you can't do it when you know you're going to be sued for $5 million. You're going to have $140,000 of loans the day you graduate, and then you got to do 5 to 6 years of residency, and then you're going to make $75,000 a year. You just can't do it coming in. So you can't cut anymore there, so you have to transform the system. So what has to happen is not just cut. It can't be tolerated anymore, but come in and transform the system. And without going into too much detail, this is the way it needs to be done. We need to go to a defined contribution system, a premium support system, and basically it would be as follows. You don't have to do it now. There's plenty of time to get ready for it. People who turn 65 actually get vouchers, actually get, say, $15,000 apiece. They purchase private Medicare certified health insurance plans like many do today in Medicare Advantage or other types of managed care that are out there today. The voucher will increase about GDP plus 1% a year. It's not 2%, not 2.5% as it has historically. The providers are going to have to figure it out. You are going to have to get doctors together with nurses, get together with facilities in order to figure out how to control those costs through integrated healthcare systems. Those payments will be adjusted by geography and severity and health risk and by income. Secondly, we go ahead and move the Medicare age up. You don't have to do it right now. We're not going to even start for another 10 years, but between 2021 and 2032, raise that eligibility only 2 months per year from age 65 to 67. And thirdly, you do limit the growth of Medicare spending thereafter, and it would again be indexed to per capita GDP plus 1%. There's a lot of detail, and I left out the rest of the slides. The main point is there are ways to fix the system, but you have to reform the system. You can't just keep cutting. And the mentality in Washington today is just keep cutting, whether it's the physician payments or payments to facilities, and that's where most of the money is being spent, just keep cutting. That's why, in part, out of 120 people graduating from Vanderbilt last year, where I am, only 2 go into primary care. Only 2 out of 120 go into primary care. Why? Because reimbursement today is less than it was 10 years ago in real dollars for primary care physician. It doesn't make sense, but in Washington, it's the only tool that you have until you reform the system. At the state level, just to set up the governor a little bit and some of the discussions before, the bottom line is that we're taking healthcare reform, national healthcare reform, and pushing it down to the state level. The 32 million people, 16 in Medicaid, 16 in exchanges, really 24 in exchanges by the time we have the flow in and out. The problem with it is the economy is terrible. And I'll show you a slide historically. States have never, ever in the history of America had such deficit spending going on. And I'll show you the slide here shortly. How are they going to do it? Because all of a sudden they're responsible for these 16 and then 16 plus 16, 32 million people, and they don't have the actuaries, they don't have the data system. A state exchange has never been invented, yet it's got to be up and running in 2 years. That's the challenges that governors have. So Medicaid plays a much larger role. States are responsible for the implementation, both in terms of the private insurance and Medicaid and the budget pressures. Graphically, the budget pressures, just look at over on the right. So this is deficit spending, 50 states, deficit spending. How bad is it? Right now in 2010, about $191 billion. Yet we're putting this huge burden on states. Coming in just in getting it set up administratively. Next year, projected to be about 130, 125. Historically, in the last big recession, how bad did it get? These bars over here, $80 billion. So this is unprecedented, but we're putting this huge burden on the states. So it'll be interesting. Again, let's see what the governor's plans are, because he wasn't there. He's inheriting this, but he wasn't there. But he's going to need you to actually fulfill at least the vision of increased coverage. This is what the governor will tell you about. I'm not talking to the governor, by the way. But this is what he's going to have to talk about in part, or this is what he's thinking about. The governors, they're concerned because they've never had an exchange before, number one. Number two, they are the ones, all those health insurance reforms, they are carried out and engaged at the state level, the whole management of the commercial market. Number three, simplifying the eligibility system. That's something the state has never had to do at the level it's going to have to do. They don't have the computers. They don't have the data management. At best, there might be one actuary in a state, and it's going to take 4 to 5 to 6. Where do you get those? Because all 50 states are going to be looking for those state actuaries. It's going to be tough. The health system capacity. Is there enough primary care when only 2 out of 114 people from Vanderbilt are going into primary care? Right here in Alabama, in nursing, are we producing enough nurses to be able to complement and supplement and work on teams to take care of these 32 million more people? Dual eligibles are the sickest. They're the people who have Medicare and Medicaid. All of a sudden, they're going to totally fall to the state and not the federal government. The data collection I mentioned and the communication. How in the world do you communicate with people in your state when a governor is responsible for 3 things? Security, maybe number one, not in the dollars. Number 2, education, K through 12, education, other education. And number 3, healthcare. That's it. And all of a sudden we're coming in and saying, you're going to have to spend a lot more in healthcare. What's going to get hit? K through 12 education. Now back up to debt, deficit, GDP. To grow our economy, what does it take? An educated workforce. But because of this bill, the governor's going to have to maybe not cut K through 12 spending, but certainly not spend more on K through 12 education. We're 26th in the world in math and science in the 12th grade. Math and science is where the innovation and creativity and job creation comes from. A state like Tennessee is 46th in the nation. I'm sure Alabama is about the same. So in the world in K through 12 education, we're 26th. There are 25 other countries better, more competitive. They're going to get hired. Their kids are going to get hired before ours. And then in America, Alabama and Tennessee and Mississippi and all of us in the South are at the bottom of K through 12. Yet the governor who speaks to you today is going to have to not invest as much in K through 12 education coming forward. Real implications because he has to balance his budget. The providers themselves, if Obamacare doesn't do the cost issues, it's going to have to be decided by the marketplace. And the marketplace is business, it's consumers, it's purchasers, it's people who are out there. Market-based solutions, it depends on what your ideology is, but with mine, over time, for sustainability and preservation of research, and companies like Pfizer, you know, we can be sort of critical of, but at the end of the day, if you've got Alzheimer's or you've got multiple myeloma or you've got heart disease, you want them out there doing research today. And so I'm a great believer in the capitalism and in the marketplace to actually define in a really transparent, accountable system. And we don't really have that today to actually work. An example of what that could be done, just to give you some images, I was at Fairview in Minneapolis the other day, who are putting together not a government-sponsored accountable care organization, but just doing it on their own. It doesn't have to be government certified. You could do it on your own to have an integrated model supported by the providers, supported by the business community. And what they've done is basically said, let's make primary care the center of our integrated model. That means we're going to have to align incentives around that. If 15% of the patients in the healthcare system account for 60% of the cost, let's concentrate on those 15%. Yes, we need wellness programs, we have to have behavioral management and all that, we got to do it, but let's concentrate our health service resources on those 15% and focus on them with health assistants, personal assistants, doctors, and nurses. Developing evidence-based care algorithms, have those care algorithms work through this patient-centered coordination, and have this feedback loop in terms of clinics, both location of clinics and how healthcare is delivered in a 21st century knowledge-based, integrated, patient-centered, with patient choice system. Now what they have found, which is interesting, let me just skip through, because it's a shared savings model, which the next chart will actually explain. They have about, right now, $1 billion right now in expenses. And in that line, the red line shows what their projected health care costs are to be. But having a shared savings system that is fully integrated, IT information technology is a big part of that. You can achieve savings that are the following. about 10% in the first year, 18% the second year, 25% the third year. In a shared savings model, which is what is used and it will be used in these accountable care organizations, that is in the federal legislation, if you do have these savings, you get part of the money, and the insurance company or whoever's paying for it gets part of the money. The good news about that, in these truly integrated, accountable care organization care models, is that all of a sudden you can take that savings and give $70 to the payer. The payer has to align these incentives and loosen up the way they reimburse and redirect their reimbursement to make sure primary care could get paid more. And then the other, here on this chart I have $220 can go to the providers, the health system, the nurses, the doctors. And that these are savings, so this is new money coming in. And I would argue that new money ought to be focused on primary care. Make the primary care physician the centerpiece, and this patient-centeredness centered around the person who is there with the intimacy every day. And with that, you have a quarterback throughout the system. I use all that as just an example. Instead of talking about accountable care organizations and all of it, that it is real, and it's out there, and you can do it now. It takes leadership of hospitals, of hospital systems, of facilities, of home health care, of hospice coming together, nursing organizations coming together, but it can be done. Business and employers, again, we're going to spend an hour on this. Wellness programs are one way to do that. In Starbucks, all of you know, the coffee costs that much, health care costs that much. Starbucks spends more on health care than they do on coffee. And the GM figures, as all of you know, I put it on here, healthcare costs add $1,500 to $2,000 to the sticker price of every automobile. Healthcare is the most expensive benefit. Just one way, and again, this is not what you're going to hear about later, but the wellness programs, there are companies like Dow who have integrated wellness workplace programs, and if you look at their studies, I put it on the right here, Dow Chemical saved more than $70 million over 10 years from a healthy workplace program. The return on investment is about $4 per dollar spent from increased productivity based on a review of 72 articles if you review the literature. It's not the only answer, but it is very important because the workplace with 150 or 170 million people is where that contact can be with enough direction now that healthcare is more continuous and not just acute responsiveness based. Informatics, Dr. Harden, and I haven't really talked very much about it, but I have to give you one more graphic. The graphics to me are just helpful from a teaching standpoint to what is informatics? What's this information technology mean? Medical records in and of themselves slow doctors down. It decreases productivity. You see 15 patients when otherwise you could see 20. Now the policymaker and the Washington people, all that stuff, they say, no, it's got to be efficient. Computer, you got to make it. I can just tell you, it slows you down. So doctors do need to be paid in some way. So President Obama put $20 billion in, that doesn't even touch what it actually does, but it is good. So this is the way I think of informatics, and Dr. Harden has a fantastic initiative underway that I hope is supported by all of you. He didn't pay me to say this, but I believe it, because it is where much of the answer to have a transparent, accountable system is. It's the only way markets are going to work. But here it is. This is the way I look at it. And again, look at this big cross here. Decision support, automation, connectivity, and data mining. Decision support. Bill Frist does a heart transplant. I know that stuff well, so I start my patient on cyclosporin. Doctor who's taking, and all of you know the number of people, there's a 747 going down every day in America, every day from medical errors. Decision support. So automation and decision support is important. So I put it in that quadrant. In the quadrant over here of connectivity, that means Bill Frist heart transplant office connects with Vanderbilt University, connects with the pharmacy, connects with the social worker, connects with the cardiac rehab. It doesn't exist today. People like to say it does, but it doesn't exist today. The power there is distributed work. If I don't have to send my records over to the hospital doesn't have to repeat the MRI and the CT scan. Information access, down here, data mining, you got to collect all that data and you put it in repositories somewhere. It might be hospitals, it might be a hospital system, but what that allows is information access. Anywhere in the country, you can pull up Bill Frist, the patient, and you can get the information. The pattern recognition and visualization is future stuff, And this is where the informatics comes in. It's fun. It's data speaking to data, because we can at best, in about 3 minutes, take about 8 good pieces of information and make a full decision in 3 minutes. If you have informatics, data speaking to data, you can process about 20 pieces of information coming in. Now, so use this sort of real quickly. Where are we today? Automation, electronic health records, just get them electronic. We're not there yet. And I believe in them. I'm just telling you, the productivity is a problem in the short term. But this is about where we are on the axis. Decision support, we're getting started. Haven't even started. We can save 747 full of people every single day by playing that out. Connectivity, you don't connect. If you go from one doctor's office to another, you're either still carrying it. If it's an x-ray, now it's a little bit better electronically, but we're not very far out. And we haven't done very much about it. The stimulus bill put $20 billion into it, but it's still not going to actually take care of the bill. This slide shows that in America, from the business standpoint, it doesn't spend anything on healthcare IT. You look at what these other fields actually do, IT spending, finance, utilities, this is how much they actually spend in dollars per employee per thousand. We way underspend in healthcare today, so it is going to take a continued investment. Individuals and families, so we're sort of going through these, and this is the last one. It's going to come down, we've got to get smart consumers. Right now, when you go into a grocery store, you have a pretty good feel for the price you're buying, the quality, maybe, maybe not. In healthcare, you don't. So it does take this informatics, this automation background, and transparency and accountability, but this push to consumerism of having millions and millions of decisions made every day, feeding into a system that has value, outcome, results in the numerator, there is what we need and what we can get to. And in part we can get to it because of the internet and because of data. 5 years ago, people would go to their families to get healthcare information. 10 years ago, they go to their doctor. Today, the number one source of information for any healthcare problem out there is the internet. We're going from a patient-focused to consumer-focused. It's not just people who come in to see the doctors that we need to focus on. It's the people who are at home, who are out buying things every day. That's where the behavior management is. It's where the wellness programs comes in. It's where we fight obesity. It's where you stop smoking. It's not in the doctor's offices. Healthcare is continuous, episodic. It's not just when you have your heart attack that you focus on health. But it is that prevention. It is that cholesterol. It is that let's move campaign of Michelle Obama so our kids will get out and move. Consumerism matters. If somebody comes in my office and said, Senator Fest, everybody likes you and you're a good guy, you're a nice guy. I want to see your data. You have a 93% or a 94% survival. What is your infection rate at 3 to 4 months? I want to see your certificate, where you went to school, and how much continuing education. How does that affect me? I go do all that stuff. I go sit through these CME courses and all of that. Consumers asking questions change my behavior, not just for that consumer, but for everybody else who might potentially come in my office. So consumerism actually matters, and matters significantly. And I mentioned a little bit about the wellness programs themselves and the importance there. So where are we going with consumerism? Because this is as local as you can get. We're going to personalized medicine, and we're going to personalized health. And things like genetics, we're learning a lot more about, don't know a lot now, but genetics determines about 30% power in terms of how long you live. So it's important stuff. Behavior determines about 40% power in how long you live, what you eat, do you smoke, do you wear seatbelts. Socioeconomic status, how rich you are, only about 15% of how long you live. You think it would be more than that. Environment, about 5%. In health services, is only 10%. Only 10%, all this hospital stuff and doctors, only about 10% of how long you're going to live today. So what we need to do as a society is link health services to that 40% impact of behavior. And if you're in a hospital, you have to think wellness. If you're an employer, you have to think wellness. If you want to have a diminution on the burden of illness, the burden of disease, the cost of disease in America. I'm going to go through this. I think I'll skip through that, and I'll really close with this. This is sort of what we went through, again, sort of just to set the framework. It's fun stuff, a little inside baseball coming in, and how decisions are made. The question is, can we do it as a nation? And we can. I've had the privilege of being able to cut people's hearts out and put them in every day for years, and being in academic centers and writing and running research labs, and then lost my mind and went into politics. But while I was there, I had the opportunity to run the United States Senate, and I've really seen it from the inside, and I can tell you it works. It's messy. And what I showed you on Inside Baseball, you say, are you kidding me? Cutting all these deals? But that's the way it works. And at the end of the day, this healthcare thing is going to work. And America can rise to the challenge of the debt. Remember, greatness of America, debt, entitlements, Medicare, healthcare cost, valued healthcare system, value, not just fee-for-service, and that's the answer. And that's our responsibility. We've done it in the past. 30 years ago, when I went to go around, or 50 years ago, when I go around with my dad, there would be 50 iron lungs for people with polio. Since a little vaccine 30 years ago, the last 30 years, over 6 million cases of paralysis, 6 million cases of paralysis have disappeared. Can you change behavior? This obesity thing, can we do it? Yeah, we can do it. We did it with smoking. I'll show you here shortly. And the heart disease, number one killer in America. Number one killer in America when I was in medical school, when I was a resident, we cut it in half. America can rise to these challenges. Just graphically, this was the red is polio, the big old iron lung. The purpose of the iron lung is to expand your lungs and all, because you're paralyzed, so you get an iron lung, your head's out. And when it's terrible, when you had to go to the bathroom or something, you open the door, and there's this big rush because your lungs would collapse and you turn blue. But that was the way we would treat everybody. All that's gone. Most of you haven't, I know you haven't seen the last 30 years in Ireland. The red is where we were, and there it is. There's where we were last year. There's very little red on it. This is where we are. 6 million cases of paralysis have been prevented. We can do great things. We can do great things. That's science. What about behavior? Can you really change behavior, this obesity thing? And the answer is yes. And I'll just show you the two statistics. In 1965, you had 50% of the population, 18 and older, smoking, and that's men. But look where we are today. It's cut down to half, less than half, 24 million people. And then third, the big things. Can you address the number one killer in America? And the answer is yes. My own field of cardiac surgery and cardiology, a great field, number one killer in America. Look at what we've been able to do. And this is really just to show you we can do great things in the country today. But here we are. This is in 1950. This is 1900. This is 2000, 2006. And indeed, you see, when I was born in 1952, cardiac disease was still increasing, and this is, I have to brag a little bit because that's when I was in the field. And I always brag and say, it's all going down because of me. In truth, heart transplants had nothing to do with it, but look what America was able to do in cutting the incidence there from 1 million deaths down to about 800,000. And with that, you can see that America is unbelievable. Its ingenuity, its greatness, its creativity, its dynamism, but old Jerry Garcia, somebody's got to do something. And it's just pathetic that it's got to be us. Thank you all very much. Great to be with you. Yeah, too much. That's a lot of stuff. It's a lot of stuff. I tell you, it's going to be a lot of stuff, but it's fun for me, and hopefully it'll give you the framework for today. We'll take 3 questions, and about anything that was said or anything else that you might have questions about at all. I got to have a question. It'll hurt my feelings if I don't. Yes, sir.
All right, Senator, in order to make progress here, we obviously have to have leadership to create a consensus, but we got separated from politics. Is that possible? How do we do it?
Yeah, the question is to make it happen, and I brag on Obama because he showed leadership. And seriously, he showed leadership where everybody else has failed on it. I would have disagreed in terms of how it was done and all, but he showed the leadership. Do we have leadership in health care? I think there's a vacuum there. In the Senate and in the House of Representatives, nobody is a Ted Kennedy type person who basically says health care is the most important thing out there. So on the legislative branch, we don't. President Obama has to focus on jobs. He's going to try to preserve everything. So at the national level, I don't see any great leadership coming. I will try, and I'm out of the political business, but I joined the Bipartisan Policy Committee with Tom Daschle, former majority leader, and we do a lot of this around the country. We're on the outside. I think he may not be out of politics, but I think he is, and I'm out of politics, so we can call it like it is. And we come from two different parties. We're going to add each other and engage in all the rhetoric. So at the national level, it's going to be that kind of vehicle. I get on a plane in a few minutes and go to Washington, D.C., and I'll be with President Obama's chief policy advisor, and I'll be talking to healthcare, and I'll be talking to Mitch McConnell, who runs, who you heard up here is just at a different place. So we'll work that. At the state level, it's going to be the governors. Huge responsibility because it's all been dumped on the governors, and it's hard. It boils down to healthcare, education, security for you, and they can't borrow money indiscriminately like. And then ultimately, you're going to hear about it in the next couple of talks. It's the real answer is you. It's business, it's consumers, it's communities coming together, it's hospitals getting together with behavioralists, getting together with people doing yoga and health clubs and all that, getting together and focusing. And obviously I put a lot of emphasis on K-12 education, so we'll have to see. We got to make the case. What I try to do is get the big pictures out there, say we can do it, talk a little bit about what Washington has done, but at the end of the day, it is you. Yes, sir. The question is, will Congress address tort reform? And the President in the State of the Union said they will. I doubt anything significant will be done. It'll be done at a state level, following the lead of states like California, who had, since 1970, a very good system. Texas 4 years ago, so most of it will be at the state level. Our governor, Governor Haslam, will probably do some fairly significant, in Tennessee, significant tort reform. The President said he will do it, but the lobbying, the trial lawyer lobbying in Washington is so strong. There'll be some studies and a little bit, but nothing significant. I will say that there's no cardiac surgeon that I know in Tennessee that has been sued for less than $5 million. And when you're talking to a medical student and they hear what's going on in Washington and they say, I'm graduating with these loans, I know I'm going to be sued. And the suit is not the money. It's going home every night with your kids saying, why did you kill somebody? And it goes on for 4 or 5 years. Yes, it's eventually settled, and you usually don't have to pay for it yourself, but that's the killer itself. One more question. Yes, sir, in the very back.
Realistically, in your timeline, if the individual mandate and the constitutionality kills the health care reform bill as we know it, in the timeline, it seems like that's what brought insurance companies to the table, some of the specialists to the table. If you don't have an individual mandate, how do you get those against this type of reform and cost? How do you bring them back to the table without the mandate that brought enough business to support the reforms?
Yeah, the question is basically, we'll go to the Supreme Court. All these district courts, it doesn't really matter very much. It'll go to the Supreme Court. The question is individual mandate constitutional or not? If it's constitutional, right now everything falls. That can be fixed. That can be fixed. So all the insurance reforms that are out there. But your point, which is the key point, and that's why in my triangle I put them right together, that if you don't have an individual mandate and you don't bring in people, the insurance systems can't really happen. You can't guarantee coverage for pre-existing illness unless you get everybody into the room. Most of the health insurance reforms themselves require everybody to be into the room and not 40 million people out or 20 million people out. I predict that the constitutionality probably will be unconstitutional, but in some way it will be framed that 90% of the people are going to be coming into the market. But the severability of what you're saying is exactly right. You have to have the individual mandate to fully accomplish the insurance reforms. If the mandate falls, the whole bill will not be unconstitutional, but if it were, there is bipartisan consensus to put those health insurance reforms back in. But it's a real challenge, and that's why the President put the individual mandate in at the beginning. You got a great conference. It's been my honor to be with you. I don't know, I have the only advantage in that I'm in this stuff all day. I practiced medicine for 20 years and then in the policy world for 12. I'm on it. I'm staying on it. I don't have the answer. I've got the models and I can work, but at the end of the day, it's rooms like this, I promise you, and people like you who are going to be able to pull together the smarts, but mainly common sense, to come together as teams to address the big issues of the financing and the organization and the delivery of health care. That's the policy. At the end of the day, it's that everybody in America has access to affordable health care so that they can live a fulfilling and a productive life. Have a great day. Thank you very much.